right, we're officially at the 12:03, so I will get us started. Thank you all for joining. We really appreciate it. And we're really excited about today's presentation. So I'd like to introduce Dr. Jennifer Dickman Portz. She's an assistant professor in the Division of General Internal Medicine at the University of Colorado School of Medicine. She received her MSW from Boston College and her doctorate from the University of Denver. Her research focuses on the development of patient-centered digital health that can be used by older adults, their caregivers, and providers to effectively improve health decision-making, self-management, and health outcomes. She is currently a NIA Beeson Scholar. She leads the Palliative Care Cooperative Group's PCRC Digital Health Interest Group and the Hospice and Palliative Care Interest Group for the Gerontological Society of America. So welcome, we're really excited. Thank you.
Yeah, well, thanks so much for inviting me today. I really appreciate it. It was so nice to meet, Drs. Wolf and Lindquist at the Pepper Center, the National Pepper Center meeting. I don't typically have the opportunity to attend that meeting. We don't have a Pepper Center here at the University of Colorado. So it was a really wonderful meeting to go to and to meet so many of your colleagues. And so thank you very much for having me today. I'm excited to talk with you all today about my work in digital health and palliative care, specifically with older adults and their care partners. I do just want to quickly thank the funders who have supported this work, particularly the National Institute on Aging, and of course the Aging Initiative, which supports the NCC Scholar program that connected me to the colleagues and why I'm here today. So thank you for that. So as a young investigator or as a young social worker, I became very interested in digital tech or digital technologies for older adults because I was working for Kaiser Permanente, and we had all of these initiatives in place to support chronic disease management specifically. And I was really interested in the idea that, what are the effects of aging in engaging and participating in technology-based interventions? And this idea that we are potentially helping older adults not only change their behaviors in health, but also change their behaviors in adopting and using new technologies. So, and making our interventions in a way that would sort of support both of those changes. So when I talk about digital health, what I mean by that is it's pretty much any digital technology that's used to support health services or personal health. And that can include anything from mobile applications, text messaging, to patient portals, to electronic health records. And I just personally thought this was a really pretty picture to sort of capture the enormity of the opportunities in the digital health space. Luckily, though, the National Academy of Medicine just put out this wonderful discussion paper regarding the potential of digital health. And so they sort of captured the potential of digital health in these main categories, and really to improve diagnosis and treatment, ensure continuity of care, off-site management of patients, partnering individuals for support, and reducing errors and waste. I would say most of my work really focuses on this one bucket of partnering with individuals to support self-management. And so most of the interventions I'm going to speak about today really relate to this bucket. I'm also specifically interested in digital health related to self-management, but also focusing on older adults with serious illness. As you know, nearly 1.2 million older adults will die each year of a serious chronic condition with different trajectories, some of those being long, some of those being short. And there's also, majority of older adults are also experiencing multiple chronic conditions, meaning that they have at least more than two chronic conditions. And so I'm really interested in those two populations the most. But I'm also, and as people have chronic conditions and multiple chronic conditions, they experience a spectrum of biopsychosocial symptoms. Here you can see a large percentage of people with various diseases experiencing pain, depression, anxiety, etc. But the individuals also experience social and spiritual concerns while managing their serious illness or chronic conditions. But I'm not only interested in just the patients, but also their family, friends, caregivers, care partners, as I often refer to, is that they are also at risk for mortality, increased risk for chronic conditions, increased risk for multiple chronic conditions, depression, anxiety, and also experience a wealth of unmet social and spiritual concerns. So a lot of my work focuses on self-management, older adults, as well as their care partners. So before I get into some of my specific projects, I'd really like to just make the case that, older adults will use technology. I would say pre-COVID, this was maybe a harder sell, but you can see here that the use of smartphones, the use of social media, as well as tablets, has increasingly grown over the last 10, 20 years. And older adults are willing and able to use digital technology. They may just have some slightly different needs, which we can get to throughout the presentation. I also want to show this, this graph here. This is the number of US respondents to a Pew survey that said that they do not access internet. So you can see that only about 7% of people will state that they do not use the internet at all. That 7% is primarily individuals over the age of 75. So while we know older adults will use technologies, they are interested in using digital health, there is still an access barrier in terms of using the internet as well as other digital technologies, so being mindful of those things. In addition to the uptake of older adults using digital health, there has also been an explosion of resources and interest in the academic space for creating mobile solutions and digital health solutions that support patients in health systems. And you can kind of see this early explosion in funding and publications, not only here in the United States, but really across the globe. There was also the rise of the digital health consumer. So this idea of more people using digital technology, the type of digital technology in the first graph, you can see not just websites, but really using other types of smart scales, wearable technologies. People are increasingly using these types of devices to support their health management. They're also using these devices to communicate with their health providers. And for any of you folks who have to respond to portal messages, you know that people love using the portal as well as these technologies to communicate specifically with their providers. Then there was the COVID effect. I think a couple years ago, people would say, "Oh, older adults, they don't want to use your mobile app." And I think the tune is changing a little bit. I mean, during COVID, people really had to use these resources. There weren't a lot of choices. It may have been their only way to connect with the health system. It may have been the only way to connect with their families. And so we really did see a huge explosion over the last few years in sort of the uptake of digital health, particularly telehealth, in the last few years. There's also a growing interest in the use of digital health in caregiving. So caregivers are more likely than non-caregivers to use technology for health-related purposes. And so there's just a huge need in sort of designing and developing technologies that support caregivers as well. So my research is really focused on three specific types of digital health, meaning mHealth, mobile app creation, and mobile software development, as well as telehealth, specifically virtual visits of some sort, synchronous virtual visits, as well as the patient portal. So today what I'd like to do is actually go through just a few projects and work that I've done related to these three specific areas. So I was specifically interested in, mobile apps. In 2018, 2019, there was over 400,000 commercially available apps related to health. And I was really interested in seeing, well, how many of these apps are related to sort of palliative care domains, as well as, individuals who have serious illness and their caregivers. And so we looked at both commercially available apps and also the literature to see if we could identify apps that specifically targeted sort of a palliative care setting. We found 9 research apps and 22 commercially available apps, and these focus primarily on symptom management, decision-making, as well as grief. The interesting thing I think we found, though, was that the research apps that were really developed from sort of clinical researchers was that the apps were disease specific. They did not target individuals that had multiple chronic conditions. They were often excluded from studies. They were connected to the clinical service so that it would sort of prompt some sort of clinical trigger in some way, and that it targeted patients, not families or caregivers. The commercial apps on the other side were standalone. They did not connect to a clinical practice in some way, which makes a lot of sense. But they also included flexible functions for multiple symptoms, multiple conditions, and they also had functions for both patients and families. However, one of the limitations in this area is that the functions were only one directional, so that the patient would interact with the app and that the app would give some sort of report to the caregiver. There wasn't really an interaction component to support the caregiver or have caregiver provide feedback or participate or engage in the app. It was really one directional. So I then became really interested in this idea of, okay, we're not just designing mobile solutions for a patient, we're designing solutions for a patient and multiple family caregivers, maybe their primary caregiver, as well as their extended family, their social support network. And so I was really interested in this idea of using social convoy theory, which is the idea of, complicated relationships that are giving and receiving care over the lifespan. And using social convoy as a way of understanding how we can design digital tools for both patients and their multiple caregivers. And designing tools that meet the needs of different types of caregivers. Primary caregivers may have very different needs, digital needs, than maybe a more extended caregiver who is helping with financial support or health decision making in some way. And so we designed the Social Convoy Palliative Care mobile application. We worked with 30 older adults, specifically with advanced heart failure, and their convoy members. It's a little tricky here because it says we interviewed or worked with 30 patients and 30 caregivers or convoy members. It looks like there was, sets of dyads, but in reality, what we found was that we would recruit a patient and as many as 6 of their family members, and in some cases, as few as no caregivers. Some participants didn't have any caregivers. So that's an interesting mix of social convoy members. And of course, healthcare providers to make sure that, we weren't missing any of the major domains. And so we developed the tool to have sort of a comprehensive self-management approach for both patients and their convoy, including palliative care domains and various types of tools for diverse users. And so you can see here is that we have different hardware platforms that are available based on who you are in the social convoy. So obviously, if you're the patient, you have access to all of these tools. If you're a primary caregiver, you have access to all of these tools as well. If you're more of an extended caregiver, you may have access to just the portal or just the mobile app, but may not have the wearable watch and the tablet. And so there's a 12-week plan that goes with Convoy Pal, and it includes multiple tools, which I'll show you on this slide, including goal setting, symptom monitoring, psychosocial spiritual assessments. We did integrate our system in with 2 mobile apps. We wanted to keep it simple. So we only integrated with Pandora and a life review mobile application known as MemoryWell. We also have tailored responses based on people's psychosocial spiritual assessments and provide specific palliative care resources based on people's responses to these assessments. So we first tested the acceptability of Convoy PAL with 26 patients and caregivers, as well as additional providers. We conducted these via Zoom. Unfortunately, we couldn't do them in person with people engaging specifically with the technology as COVID was hitting. And we also used the UMARS, which is the user rating of the mobile application rating scale, to test the acceptability of Convoy PAL. We also asked specific questions around recommendations for improving the tools. What we found is that both patients and their caregivers thought it had good acceptability, with scoring about 3.9, 3.7 out of the 5-point scale. People felt that it was functioning. They particularly liked the information that was provided by the tool. And we did get a median 4-star rating on the tool, and every single participant said that they would recommend it to someone. So we felt like that was a pretty encouraging result. We did get some feedback around monthly goal setting, around the self-management goal structure as to, do you do it monthly? Do you do it weekly? And different participants had different feedback on the goal setting process. They wanted even more tools. I think we offered them the watch, and they said, hey, can we have a scale? Can we have an oximeter? So there was always an interest in having sort of more tools, more access to more resources. There were some concerns around privacy related to the exchange of information between the caregiver and the convoy, or the caregiver and the patient. We've been able to address this through research, as each individual is consenting to the process of sharing the information. So we spend a lot of time talking with people prior to enrollment. But in a real life setting, this does become particularly complicated. And we'll see this down the road when we start talking about portals and the sharing of health information between caregivers and patients. And also the concept around depersonalization is that, serious illness is a very difficult time. And so should some of these topics really be digitized? Is it appropriate? Is it meaningful? And there are some concerns both by providers as well as patients and caregivers that these topics may be too sensitive for digital tools. So we did actually integrate some of the feedback. We updated the solution, and we're currently in our feasibility trial right now. So more to be determined in maybe a year or so. I can come back and give everyone an update about how feasible this tool was to deliver in sort of a clinical and community setting. The next area I'd like to talk with you all about is my work in telehealth. And this has really been a very big topic over the last few years with COVID. But we know that telehealth produces positive health outcomes. We've known this for a long time. We also know that it's non-inferior to usual care. We know that it's safe to deliver, and that we actually see increased satisfaction among patients who participate in chronic disease management telehealth. There's less known in the palliative care setting. There were several trials sort of embarking or recently concluded prior to COVID. Some of those trials had to shift over because they were direct randomized controls between telehealth and in-person. And so how they shifted those designs, I'm actually not sure, but it'll be interesting to see how those groups managed those shifts in their trial. We also know that in hospice setting, there's been an increased interest in using telehealth as well. Prior to COVID, we conducted a non-inferiority trial with a local hospice organization, and we determined that conducting the face-to-face reauthorization visit was just as successful doing it completed via telehealth as it was in person. And so that was a very exciting result to see that we could even do it in the hospice setting. One area that's sort of really open to investigation is the use of mind-body interventions via telehealth. There have yet to be large-scale randomized control trials for yoga, which is a particular interest of mine in older adults. And so I'm going to talk to you about a trial in just a second. Most of these, yoga-based online trials, again, exclude individuals with multiple chronic conditions, and rarely do they target care partners. So one of the telehealth projects we have been interested in, my colleagues and I have been interested in trying or designing over the last, 5 years. We were doing a lot of this in person, and then we moved to telehealth over the last 5 years, is creating My Skills Mobile, which is the merging of yoga and self-management skills in a mobile format. So we target older adults who are 65 years of old. We've actually 65 years of age or older. We've actually moved to include individuals 60 years and older. We target individuals with multiple chronic conditions, those who are experiencing depressive symptoms, and we also invite their caregiver or their care partner to participate in the intervention as well. The intervention includes 8 weeks of both yoga and self-management. So you have 2 sessions per week via Zoom. Again, the dyad is optional, it's not required, and I'm happy to share more information as to why we moved to an optional format. But we provide 60 minutes of yoga that focuses on a symptom or a topic that relates to the self-management topic. And we also include 15 minutes of synchronous self-management review that would go over goal setting, as well as problem-solving solutions among the group members. And then each participant has access to asynchronous self-management, which is sort of a lecture, educational opportunity, plus a self-management activity that lasts approximately 30 minutes that they can complete over Canvas at any time during the week. We have conducted My Skills Mobile in two settings and 2 groups here. One was focused on dyads with chronic pain. These individuals were about 63 years of age. They had average 5 chronic conditions, and depression was rated number 2 as the most common. In our second group, the individuals with MCC, these individuals were on average 70 years of age, again, with about 5 chronic conditions, and 9 of these 33 participants were care partners. And so we find that our studies are very feasible. We're able to screen individuals into the study. We're able to consent them. Interest is pretty high. We also have fairly good attendance to both the yoga and synchronous self-management. You can see about 75 to 85% of sessions are completed. We have pretty low attrition. We are very lucky to say that we did not have any serious adverse events, which, delivering yoga in a virtual format can be a little intimidating for the first time. And so we have been very successful at keeping our participants safe. People are very satisfied with the intervention. They really like participating in the yoga and self-management in a virtual format because they don't have to go into a clinic. They can actually participate in the intervention in their home, and that makes them feel really, really comfortable. We've also seen signals to suggest that there are improvements in depression, self-management, as well as care partner and social support outcomes. But again, these are small sample sizes, but we do see improvements in these areas. And the last area the last digital technology I'd like to sort of cover today is my work in patient portals. And I'm sure everyone here is very familiar that patient portals are these secure websites that are directly linked to the electronic health medical record. And it typically includes, depending on what system you're in, access to medical visits, records, medication, pharmaceutical refill packages, things like that. Patient portals have been shown to improve access to health records, self-management, patient clinic communication, as well as patient satisfaction. There's pretty mixed results on whether or not patient portals improve healthcare utilization or even wastes or errors, but that's still to be determined. There's quite a few studies, and it's pretty unclear whether or not patient portals actually improve healthcare utilization. So we know that portal use is associated with age. We see sort of this curve is that as you get older, you're more likely to become a user, and then that actually declines as you get older. Individuals over the age of 70, 75 are less likely to use a portal than their younger counterparts. Health status is also associated with portal users. If you have poor health status, you are more likely to use a portal system. If you are white with higher socioeconomic status, you are more likely to be a portal user, as well as living in an urban setting. Older adults, in our previous work, we found that older adults really appreciate email messaging, viewing their labs, and as well as medication management. These are some of their favorite tools. But we have also sort of a well-documented experience of older adults using portals. There's barriers related to computer literacy, usability, usernames and passwords are always a big issue, as well as actually just getting set up in the portal. There we go. So again, I was very interested in looking at, well, how are patient portals being used specifically in the palliative care, end of life, serious illness setting? And so in 2020, we conducted another scoping review, and we found 19 articles describing 12 individual patient portal tools. These tools focused on advanced care planning, quality of life and symptoms, as well as psychological support. The majority of this work focuses on those who have cancer, and there are high satisfaction rates and high rates of acceptability and usability. Most of the patient portal work that's related to serious illness has focused on advanced care planning and in the oncology setting, not just for the actual individual patient portal tools, but looking at the associations of portal use and outcomes related to oncology care or the uptake of advanced care planning tools. So only three of these tools targeted both patients and caregivers, and there were no tools for bereavement, social support, or hospice that we could identify. So we became particularly interested in, okay, well, what does it look like? What does use patterns and characteristics of users look like in the setting of serious illness? So we looked at two cohorts at Kaiser Permanente, Colorado, their patient portal, My Health Manager, well utilized by their patients. 63% of all KPCO patients use the portal, and individuals 25% over the age of 65. Again, this might actually be low. I think those are maybe old statistics, highly used patient portal system. And what we wanted to do was describe patient portal use and the characteristics of users in the setting of serious illness. So we looked at a cohort 12 months following the onset of their serious illness. And we also looked at the 12 months, a cohort of individuals who had died, and looked at their portal utilization in the last 12 months of life. What we found was in both cohorts, portal use was extremely high. People were using the portal system 50 to 43 days in the 12-month period. At Kaiser, you see about 34 days or logins per a 12-month period. And these individuals were using it more than that. Compared to other health systems, you see approximately about 28 times per year, you would see someone use a portal system in a 12-month period. So it was extremely high. We had very low proxy registration and low proxy use. So in a cohorts of 6,000 people each, only 150 proxy users were registered. And so it was very sort of difficult to even look at their use. They used the portal systems less than one time in that 12-month period. So proxy use was very low. Again, email messaging was very popular. However, it was, it's been brought to our attention around the topic of email messaging and potential harm around the idea of a caregiver messaging a provider as logged in as a patient. And so the provider often doesn't know who they are emailing with, can be very problematic. And the other is these messages related to health results in the portal that are delivered to patients. For a very good example is, if you're getting a blood sugar result or something like that, and your blood sugar result pops up in your patient portal, and it might just be a standard, blood sugar result. But if a result for an oncology patient comes back and that you have high white blood cell counts or something like that, you may actually know that your cancer is back, and that may not be the best way to deliver news. And so there's some really interesting issues around the portal and the use of sort of standard tools in the setting of serious illness. Use of e-chat and e-visits was popular among both the patients and the caregiver proxies. And in the last 12 months of life, portal use actually increased about 7% per month over the last year of life and peaked about 3 months prior to the patient's death. So now that we knew a little bit more about how the portal was being used in this setting, we really wanted to know more about these proxy users and how we could better design the patient portal to support caregivers. And so we invited the proxy and non-proxy caregivers to participate in an interview to tell us more about their experience with patient portals, as well as potential recommendations for tools. And so we interviewed 31 caregivers over the phone. We also then conducted some focus groups with them afterwards to make sure we were on track. And some of the recommendations that they provided related to include end-of-life resources and care options on the patient portal. The idea of having multiple caregiver access, not just one proxy, but having multiple proxies having access to a patient's portal was another recommendation. These proxies were also interested in caregiver specific resources. So how can the portal be designed to specifically support caregiving, as well as having a social work referral option. And of course, I loved this as a social work, hearing people say, wouldn't it be great to have access to a social worker on the portal, as well as having continued grief support or access to resources in the portal. So these are some recommendations that proxies have provided us that I think we're interested in trying to figure out how we can better integrate these into the portal systems. So today, I think I've talked a lot about the opportunities of digital health. I've also talked about how wonderful these tools can be and how older adults appreciate using them, and how we've had so many great experiences engaging with older adults and their caregivers in their health in these sort of novel ways. But unfortunately, there is the dark side to this area of research, and there are still many challenges and barriers that we're facing. We clearly know that there is an access issue, particularly around underserved communities, those without access to Wi-Fi, those without access to actual devices. And so there are some serious issues around access. Usability continues to be an issue, particularly among older adults, of whether or not these tools are actually usable or functional among people who may be losing eyesight, hearing. All of these become somewhat of an issue as people age. Privacy and confidentiality issues, particularly for me around the issues of sharing information between patients and caregivers. There's a lot of concern among our participants around replacing live visits, and how does this change your relationship with your providers? Should palliative care and topics around serious illness be conducted in non-live settings? I think some people have concerns around the topic at hand. The impact on care and providers, as I hear from providers often, is that, the portal, they get a lot of messages, a lot of flags, a lot of pop-ups, and this can be very challenging in terms of workflow. Reimbursement and cost is always something that I think we're concerned about. Is we're creating some really great solutions, but how do these get sustained over time? Interoperability is becoming a larger issue as more tools are being created that don't actually integrate with clinical practice, and then when they are interoperable with clinical practice, how do they then impact and interfere with clinical workflows? Especially around effectiveness. We still don't know in a lot of cases whether or not these tools, wearables, a lot of these are effective in improving health outcomes. There's still a need for science to build an evidence base there. Regulations, particularly HIPAA, can be quite challenging in creating freestanding apps that support patients and caregivers, as well as timelines and cost. I know personally that creating a mobile application can be very, very expensive. And so you may actually have to limit what you can provide on that mobile application based on the cost, as well as the timelines to actually create these tools, but then to test these tools that the newest, shiniest tool has already arrived by the time you have tested your tool from 4 years ago. So all of these are major concerns in terms of the digital health space, but nothing that can't be overcome. And so I want to thank you again for inviting me to participate or inviting me to present today. And I really appreciate it. And I'm happy to answer any questions, share lessons learned, or just talk about really cool interventions with older adults and their care partners.
Thank you so much. That was wonderful. I'm going to open up to the group, see if I see any questions in the chat or any hands raised. Does anyone have any questions?
Hey, just Jennifer, this is your work is so again, as I mentioned before you started, there's just so many avenues that we hopefully can continue to talk with you, because whether it's be telehealth, use of patient portals to engage patients and families, as well as, again, lots of people in our group are doing apps. I did see, since it's a small group, not too small of a group, but a group today, that the person I mentioned to you, Dr. Allison Chi, if you want to say hello to, I wanted to make sure that the two of you introduced you, since Dr. Chi also was an MCC scholar and is doing some very, very similar work, if she was agreed. But.
Awesome. I don't think I see a face, but it is nice to meet you, and please do email me. Yes,
yeah. I will connect you by email afterwards.
Wonderful.
Does anyone have any questions? Don't be shy.
I'm known for I'm known for being too truthful, so I'll share the inside scoops.
I mean, you did allude to some of the challenges that you experienced that I think we could all really learn from. And one of those I was interested in was about the dyads, yes, and how that's a real challenge to recruit dyads. And you sort of alluded to it a little bit, but if you want to talk a little bit about how you handled that. And I
would love to talk about this issue. So, I mean, I think ideally when I first started this work, and it depended on the intervention, we were either targeting dyads specifically, or we really sort of expected to recruit at least a dyad. And I think as we got into this space, we really learned that so many cases there is not a caregiver present. And that, I think, surprised me on a personal level. I was surprised that there wasn't someone that was involved. And we find across probably most of these studies, about only 50% of people will want a caregiver to participate in a study. And so that became really complicated in terms of requiring even a dyad. And in some of my work, I'm even more interested in recruiting multiple caregivers. And so this idea of recruiting either a patient or either a dyad is really challenging, and it's also very difficult to, I think, explain to reviewers, or has this major complication in your design that includes caregivers but doesn't require them, and so everyone looks a little bit different, and that's been a really big challenge, I think, for me and my work. Yeah.
Thank you.
Yeah.
I don't see any other questions.
That's fine.
Hi, I'm Erin. I'm at UTMB Galveston. I might pick your brain a little bit about some tension. So I'm a physician geriatrician here in Texas, and starting sort of a junior researcher, but in a mid-clinician body. So I've been taking care of patients for a long time. And as I sort of venture into this space, the research around kind of web applications or optimization of the electronic medical record and these sort of portal systems, I'm struck by like the slowness at which the research side has to take, I think, by the nature of how we do things and do them well, but by the nature at which, you know, technology changes much faster, and sort of this kind of a little bit of disconnect between kind of the research space and the clinical space in that regard. And just curious, like, what your response would be to that, and how do we take the tools that seem to be making improvements in patient care and get them out to the clinical space where they can be used optimally, but still maintain the integrity of the research behind it kind of in the long term? If you have any response to that.
Yeah, I mean, I think this has been one of the major challenges that we've been, that I've at least heard people talk about this issue for, at least 10 years, around the idea that industry is just so much faster than we are. But industry definitely doesn't necessarily have, I shouldn't say that, industry doesn't necessarily have the same interest in sort of having the evidence around usability or clinical efficacy, and those things do take time to acquire. And so by the time you're done with your study, there is the newest, hottest tool available. I do think that during COVID, we did learn how to mass employ something when something was needed, and that we tested telehealth, for example, in a new way, using sort of, quasi-experimental studies. They may not have been the gold standard around randomized trials, but I do think there are sort of more novel ways that we can approach building our evidence that don't necessarily require some of the slower trials. I don't necessarily think that we can get rid of those topics as well. We can learn a lot from clinical efficacy trials, feasibility and usability trials around general design, use, uptake. So I think those are important as well, but I think we can also be creative in how we actually design, how we evaluate these new tools as they move forward. And we need to be faster about it. I mean, we're seeing this, I think, right now, most in the wearable space. There's so many watches, there's so many different options for people. Many of them are not validated. A lot of them are, some are reliable at certain measurements and not at other measurements. And so while people are increasingly interested in sort of this wearable space, I think we need to kind of hurry up and figure out which ones we can integrate the fastest, but then test them in maybe more unique ways other than doing a 4-year clinical trial. Yeah, it's a hard one. I also like partnering with industry. I don't know if the partnering with industry has been a lot of fun. Actually, I think there's, if you can find a good industry partner who's willing to sort of share your idea, I would highly recommend, working with industry partners and sort of coexisting together. Yeah.
We do that a lot. Actually, one of our Pepper scholars on this call is Allison Pack. She's doing a lot of work with projects that have some similar kind of ends in terms of kind of working on, coming to minds where you have to kind of bring some health systems expertise to, in this case, maybe pharma, who may have more of an outside view. So we've had experiences that's kind of it's a give and take, but you're right. Sometimes you can get things funded nicely that wouldn't really fit. The development work needs to be done maybe through industry support before maybe the more objective evaluations can be done through NIH or ARC or other federal groups.
Absolutely. Yeah. And it can always be a challenge to get the health system on board for, integrating your tool. A lot of times your tool needs to sort of align with the priorities of that specific health system.
All right, well, thank you again for a wonderful
Yeah.
talk, and thank you everyone for attending today. And we hope to see you again next month. Thank you again, Dr. Portz.
Yeah,
Really
thanks
enjoyed
everyone.
your talk.
Have a great day.
Thank you.
Thanks everyone.
Happy Friday.
Bye.